Awesome. Yeah, so we are going to get started. We have Dr. Towfigh here, and the way this is going to work, this is typically done for our GFAM members, and we thought this was such an important topic to get it out in a larger scale tonight. So we are essentially opening this up. It's on the Pelvic Guru page as well as your page, which is your name, under your name. And if you want to shout out for anything, that's fine as well for that. And we also have it in the GFAM group. So hopefully you're all tuning in, and I'm going to be looking at comments and questions. So please say hi if you're joining us. And we have a bunch of things to go through tonight. So first, what I would love for you to do, Dr. Towfigh, is to tell us a little bit about you, your background, and we'll get started.
I would love to. First of all, thanks for inviting me. As you know, we found each other on social media. And so it's really great that I get to watch what you're doing, and thank you for appreciating what I do. So I'm a general surgeon by training. I was trained at UCLA and been working as a hernia surgeon since 2002 and exclusively since 2008. So it's all I do is hernias, and that includes not only fixing hernias. Most of my practice is fixing hernia-related complications, so mesh-related problems, nerve problems, chronic pain. And then also any type, I kind of end up seeing any type of abdominal or groin pain that no one can figure out. So for example, I see a lot of women with groin pain. It's not endo, it's not ovarian cyst, you know, that kind of bikini medicine, you know, it's either their breast or your uterus. If it's not that, then they don't know what else it could be. So then they send them to me, and I hope we get to talk a little bit more about, you know, women's hernias, because that's something that, because of that experience, I've become really involved in learning how women's hernias are so different than men's. And it's about half my practice is women.
That's awesome. Yeah, that's something that I think is not on the radar enough. Yeah. And if I could say, you're in the absolute right place. This is all the types of people that are interested in that exact topic. So you have found your home with that for sure. And by the way, the social media stuff, what is getting left out is that this is years of knowing each other over social media. I'm not sure exactly how many years, but over the years, I have reached out to you multiple times. We actually were in passing, we were near each other at IPPS conferences and stuff, but
Chicago, yes.
Chicago, yeah. And we've had a chance to really connect in a lot of ways. And I asked some tough questions in terms of my patients or how to send them to you. So this has been a really wonderful relationship that we can finally showcase and share your information. So I'm really excited.
Thank you. And thanks for opening up your platform to my followers too. I know it's like mostly exclusive for your membership, and I appreciate that, but I think it's such an important collaboration for surgeons to work with pelvic floor specialists, and we often don't see each other. In my practice I do, but in general in the world, throughout the world, we don't interact as much. So I think kind of illustrating what you do and how I can help, I think great. Thanks for doing that.
And you travel all over the world. I mean, you teach and speak and train all over. So you definitely do a lot of that. Okay, so we can jump in. I have a variety of questions. And again, I'm looking at all these awesome questions that are coming in as well. So if we will kind of do a combination. I'll be asking you some questions, and then I know you may have some slides to share, as well as we'll be fielding some questions from everyone as well. Okay, so I'm going to start out with some basics so we're all on the same page. And what I like to do with these, the way I ask in these interviews is to make sure that by the end of it, by the beginning, we have an idea of what the basics are. And by the end of it, we have a lot of clinical applicability, something that we can take home and use immediately with patients, and people feel more confident in their understanding of the topic. So with that, let's talk about what is a hernia and what types of hernias are there? What is that all about?
Yeah, so a hernia is a hole that has something going through it. Usually that hole is either muscle or fascia or ligament associated. Usually we discuss it like the mostly abdominal wall, but you can have hernias anywhere. What I do is mostly abdominal wall related. And then what goes through it can be anything from, typically it's fat. Sometimes if it's bowel, those are a little bit more concerning. And then you can also have bladder or appendix and ovary through it. I mean, the esophagus for hiatal hernia, stomach. So it's really any hole with something going through it. and that shouldn't be there, basically.
And there are some people that have them. We think of this, some people think of this as only an adult problem, but actually there are kids that have them. I think one of the questions I'd asked before and was curious about, if someone had one as a child, are they more likely to have them as they grow up, or is there any correlation? Or tell me a little bit more about this, the age span and how that works.
So we talk mostly of either pelvic hernias, so mostly the groin, although there's some more rare pelvic ones too, and then abdominal wall, which is mostly around the belly button or the midline, although it can be anywhere around the abdomen. So in those patients, all hernias are supposedly a weakness, either a collagen deficit or a collagen mismatch. There's like MMP proteins that have been shown to be inadequate in those. We believe there's a genetic predisposition. So kids and adults have both shown that if you have a relative with a hernia, the chance that you'll have a hernia will be increased. And in both pediatrics, recently a paper was published on that, and more recently we've been seeing it in adults. If your mother or a female member has a hernia, that's a much stronger genetic link than if a male has it.
Oh, that's interesting.
Yeah.
Wow. With that, so one of the things that comes up a lot with this, I see this with a lot of my patients, is, okay, so I suspect I may have a hernia. What are typical symptoms? And I know, again, I think it's sometimes hard to delineate because, like you said, there's abdominal, there's pelvic, more inguinal types. But in general, what are some telltale signs, or do we need to delineate per each type? What are we looking for?
Right, so the treatment algorithms are different based on the symptoms and based on where the hernias are, as well as your age. So in children, for example, belly button hernias are pretty common. You can see like kid cries and the belly button pooches out, but those tend to close over a span of 1 to 2 years, and we don't usually repair them until they're old enough to have safe anesthesia, and many of them close by then, so around 2 to 3 years. In adults, for example, for groin hernias, we go mostly by symptoms. So there have been 2 great male-only studies that show that watchful waiting is totally safe. So if you have minimal symptoms in your groin and you have an inguinal hernia, then you can watch it. The reality is that it does get worse over the next 5 to 10 years, and about a third of patients need surgery, but watchful waiting is considered safe. For the groin in children, also we wait until they're a little bit older because they do tend to close as well. And we feel like developmentally that's a different disease process than in adults, because that does close. It's just a delayed closure of a natural hole. And then if you're really, really old, the goal of most hernia repairs, almost all hernia repairs, is improving quality of life. You're often not really saving a life by repairing a hernia unless it's done in an emergency setting. That's a no-brainer. Those need to get repaired if you're super sick from it. But if you have an outpatient and they come with an inguinal or an abdominal wall hernia, the goal is to improve your quality of life. So if they're like have COPD and they're a chronic smoker and morbidly obese and didn't even know they have a hernia, those patients are not going to benefit from hernia repair. But if you have someone who is a construction worker and can't do his job without fixing it, then you're improving the quality of life. Or if you're 90 years old and not healthy, then there's really no improvement in your quality of life by repairing a hernia. So it's mostly a judgment call based on symptoms, and specifically not based on size. Size is not a determinant of repair. There's only one exception to that, and that's a femoral hernia, which is a rare hernia. It's in the groin. It causes very specific symptoms down the leg usually, and it's about 11 times more common in women than in men.
Oh.
If you have a femoral hernia, those must be repaired, because about a quarter of them will present with a bowel obstruction, a third of them will need emergency surgery, and 5% die from femoral hernia. And that's a very high mortality. So femoral hernias, once diagnosed, regardless of symptoms or size, must be repaired. Everything else, it's really symptomatic.
What's
choice.
what are the symptoms? So because so many of us are pelvic health professionals and we're seeing a lot of these patients, what are we looking for?
Well, I must say, the physical therapists that refer to me are often much more astute about whether a patient may have a hernia than a physician. And I think it's because you all really work with your fingers and your hands a lot,
Yeah.
and you have a much better appreciation of the difference in texture and tension and swelling underneath tissue than we do. And so it's, if a physical therapist refers me a hernia, I'm much more likely to, that patient's much more likely to have one than when a doctor's like, hey, what do you think? So kudos to that, but I think it's because you actually touch patients, and
Right.
and so many doctors stop touching patients. They test CT scans and lab tests. So the symptoms are very, very important. And we are about to publish a great paper specifically outlining top features of symptoms, but typically for the groin, which is the one that's more difficult to diagnose.
Right.
It's groin pain. And let me, if I can I share my
Oh
screen?
yeah, you should be able to. If not, I'll see if I can.
See
There
if
should
you
be at the
can
bottom, there should be a green button.
It asked me to ask you as a host to enable it. But there's a great chapter that I wrote. So basically, if you draw a line from the anterior superior iliac spine to the midline, the pubic tubercle, that line is the inguinal ligament. Any pain or hernia below that line is a femoral, above that line is an inguinal. And then right at the 60-40 mark, it's not really 50-50, it's like 60-40 more inwards, is where you would feel either a swelling or a fullness. If it's a big bulge, then that's kind of obvious, but if it's a swelling or fullness, or they say, aha, right here is where I have pain, that's classically a hernia. And it radiates in women more commonly than men. It can radiate to the inner thigh. The pain can radiate around to the lower back, down the front of their thigh. In women, it can radiate into their vagina. In men, it can radiate to their testicle on that side without the testicle itself hurting. It can be painful during intercourse. It may be worse with gravity. So standing makes things fall into the hole more. Sitting closes off the groin canal, that can hurt more. Bending, where you're flexing at the hip, that can hurt more. So the typical story is, I have pain in one area, radiates around my lower back to my inner thigh. I may be bloated or nauseated. That's more like a generic kind of pelvic pain issue. Yeah. And it hurts with intercourse, and standing for a long time or sitting for a long time, like in a car ride to work, bothers me.
You should be able to share, check and see if that did open up,
Okay.
In case you'd like to do that. That's really helpful because I think a lot of people get stuck and feel like, well, I went to, like you talked about, I went to a GYN or I went to a urologist and I'm still having these symptoms, and they go through a typical round of things, medicines, antibiotics, and they're still feeling like they have it. And I really think that hernias get missed. And I didn't realize how important femoral hernias were in terms of they have.
Absolutely. Let me see if I can share.
Okay. And by the way, I don't think I introduced myself formally, so I'll do that while you're getting that up. I'm Tracy Sher. I'm owner of Pelvic Guru, and I am a pelvic physical therapist by trade. That is what I do. And we do these interviews to bring in the top experts in the world to really highlight a lot of pelvic health conditions or treatments or ways that we can help people more and bring treatments to them. So.
All right, let's see if I can share this.
Okay, let's see. And people are saying this is excellent. Howard just said this is excellent.
Great.
Have people from all over. It's so cool. From Australia and Croatia. Oh man, all over, everywhere. Ann Arbor, Michigan. Okay, cool.
So this is a paper I wrote in a book published by Dr. Campanelli on different hernia stuff. But if you just Google women or groin pain, it should come up. And so this is our initial data. Our like bigger data is being published soon, but you can see in women, most of them have pain. Men may not come with pain. and it's radiating pain to their vagina, lower back. You can see these numbers, 20%, 40%. About half of the women have some type of radiating pain. This is also super important. A quarter of them, it's worse during their period. So that usually triggers like hormonal things or endometriosis. But we do see that in women. This is classic. So if they have point tenderness over the deep internal ring, basically at that 60-40 line, if they have tenderness right there, that's very diagnostic. And this is basically where it is. So if right around here is the anterior superior iliac spine, right around here is your pubic tubercle. So along this line at about 60-40, so 40% of the line here and 60% there. Pain right there. Some think it's way down here. It's actually not. It's right there. The appendix will be somewhere around here for reference, and the belly button somewhere up here.
Okay. Wow. So it really can be by point tenderness there. That is a high degree of accuracy.
Very
like
accurate.
I said, we are touching as those of us who are in the pelvic health, pelvic PT field, we are OTs and PTs. We are touchy-feely, so we are touching that area. Okay. That's great. And if anyone else has any questions too about these different types of hernias, please ask. I know we tend to see inguinal the most in my practice at least, but there's so many different types. And the idea is there's the abdominal wall has an issue, or the inguinal region where there's just now protrusion out, and that's what causes those symptoms. So what you're saying is that, just to round up, femoral usually always has to have a surgery. The other ones, it could be a wait and see, but it's not like they usually get better on their own. Maybe sometimes in the kids in some cases, but for the most part, hernias could just be stable for many years, but at some point they may need.
Right. The studies show that in men, we think women are probably similar, we just don't know. In men, if you do watchful waiting, about a third will have surgery within 5 years because their symptoms will get worse.
Okay. And there's nothing like, sometimes as PTs, again, a lot of us will think, okay, well, what can we do to help them decrease symptoms? So there may be ideas about bracing or doing things to help, but that's really more like a Band-Aid, right? At some point, it may still not be enough of to go against that force.
Yes. So to date, we don't know of anything that will cure hernias non-surgically. However, all of the core exercises we feel are safe and probably will help either maintain or reduce symptoms. So I have patients that maybe had a hernia, went to their doctor, confirmed a hernia. Doctor said, oh, okay, now that we know you have a hernia, don't lift anything, don't go to the gym. So then they actually gain weight and their symptoms are worse, and they see me. I'm like, listen, go back, do everything you were doing before. And I explained there's a great study on, I think, medical students, where they checked abdominal pressures and had them do sit-ups and push-ups and deadlifts and also things like cough and bend and go upstairs. And coughing and jumping were very, very high in the abdominal pressure rating, but sit-ups, not much abdominal pressure. So I explained that to patients. I said, go do all the exercise you like to do. I don't like a lot of the CrossFit type intense exercises, extreme exercise, P90X, insanity workouts. Those are a little bit too much because they're so rapid and aggressive. But Pilates, yoga, any type of cycling, anything that involves the core is safe. We encourage it. And in many patients, if you bring their core back to health, their symptoms may go away and then they can forego surgery.
So it's basically just what I'm taking from this, and it's important because even within CrossFit, they can do a lot of scaling. So it doesn't mean they have to be doing the upper limits of things. They can scale. So what you're saying is basically find exercise that you can scale within a moderate range, and that's actually better than doing nothing, like staying away from every kind of exercise, but not to the extremes. So if you're doing, you may have to stop, especially if you're having symptoms, right? So if you're doing any kind of sit-up, even if you have a lot of symptoms, that's an indication to
yes.
slow it down. Okay, this is helpful. So it's great. So you're hearing this from a hernia surgeon. It's okay to exercise, but look at your symptoms, pay attention to those, and modify and scale the exercises. That's what we do a lot of in what we do.
And I think a lot of the physical therapists have a very Pilates oriented like movements that they incorporate in their physical therapy. And those are all totally safe, absolutely safe.
Okay, good to know. And I know they'll be cheering about that. And again, it's just about scaling it. So you wouldn't necessarily have them start out with 100s. It may be that they're doing, you know, the gentle things and scaling up. So with Pilates, even that.
Yep.
Okay, so there are some questions coming in. There was a question about, and of course I'm going to have to I'm going to have to say this. Someone wanted to know more about Spigelian hernias.
Mm-hmm. So Spigelian hernia is a very specific hernia. It's among the more rare abdominal wall hernias. So if you know where your semilunar line is, it's where your rectus ends and then the obliques kind of come in. So right at that border is called the Spigelian line, also the semilunar line. And classically, about 2 finger breadths below the belly button at the Spigelian line, you can get a Spigelian hernia. It's just a weak area of the abdominal wall. It's unique in that it's not a full thickness hernia. So it goes through the transversus abdominis, through the internal oblique, but the external oblique is preserved. So you don't see this like obvious kind of bulge through because the top layer of muscle still covers it. It's like a vague pain, but it's a classic position. So if you have pain in that one position, you should get some type of imaging to repair it. Spigelian hernias can be watched, but once they're symptomatic, they should get repaired.
Okay, so they're also on the list of likely just go ahead and repair.
Mm-hmm.
Okay, good to know. Then there was a question, the Carnett sign or test that we do, I know it's used a lot for visceral versus muscular around the abdominal wall. Is that useful in your practice? Do you use that? Do you incorporate that?
I use that mostly for sports hernia diagnoses. So if you have a tear of the rectus off of the pubic tubercle, sometimes that pain is midline, but sometimes a little bit on the outer edges of midline, and may kind of, people think maybe it's a hernia. So I have them lay flat, and I press right over where if this is the bone, here's where the rectus inserts. I press right over that rectus insertion, and I have them do a sit up. And if they're like, oh, that one side's not painful, the other side is very painful, that's classically a tear. And a type of like a rectus abdominis tear, which we consider part of the sports hernia type thing. Not as helpful for hernias of the groin or of the abdominal wall.
So that's actually a question that does come up. And one of the questions I had was what is a sports hernia, which you've answered. And then when someone has pubalgia, those kinds of pubic pain, and I can touch on the pubic tubercle and they immediately want to jump up and it's a lot of pain. That's an interesting distinction. Do you find anything in imaging that shows, yes, it's more of a sports hernia versus some other kind of pubic related issue? Is it very clear or harder to pick up?
Imaging should be part of the workup, actually.
Okay.
So sports hernias are typically either a tear of the rectus insertion on bone, off the bone, or a tear of the adductor longus off the pubic bone. That's the most common. There are other tears where you can get muscle tears and like a little nerve gets trapped in that muscle, in that fascial tear. Those typically go hand in hand with the other tears. It's often not surgical, so there's not a lot of workup that's done in the initial phases. But if you do get imaging, an MRI is classically the right image for that. And if it's bad enough, it'll show the inflammation associated with it. Most sports hernia tears are not so huge that you'll see an actual tear, but what you'll see are like the inflammation from the micro tears. And you can tell that nicely on MRI.
And is there a time period? So someone had something happen, I don't know, 6 months ago. Is there a period of time where the inflammatory I guess the showing of that happens for a certain period of time, or does that go away at some point? Or
so the algorithm involves 6 weeks of rest and anti-inflammatories, and we don't really want to do anything more like injections and for sure not surgery until you've passed a lot of those markers. In professional athletes that are worth like $40 million, that algorithm is out the door and they go straight to injections and even surgery in some cases. But in the average patient, it's mostly rest and anti-inflammatory. So if they still have pain after 6 weeks, we consider that more of a chronic problem. And then they need to get injections of either local anesthetic and steroids or PRP.
Yeah.
Surgery is definitely an option, but we don't really recommend surgery until they failed every single non-surgical option.
Okay. And it's good for us to know when surgery is more indicated than not. And like you're saying, the Spigelian and femoral ones are more along those lines. And then I would assume really significant inguinal and that sort of thing would be. But it sounds like you're also saying there's some that you just wait and see and you follow other protocols.
Most people
Yeah.
wait and see. There are some surgeons out there that offer surgery early on, and it's just not the right way because the outcomes from surgery are not perfect either.
Yeah.
I mean even LeBron James didn't get surgery and he just missed like 40 games or something. But even he didn't get surgery because they know that he'll be not as quick and nimble and fast after the surgery.
Yeah. And it's great to hear a surgeon saying this, don't rush and get surgery. This is a sign of someone that's looking out for patients. That's awesome. All right, so let's see. So this actually does segue into the next topic, and there's some questions about this. So you had mentioned about MRI. Is that pretty much the gold standard? Because I know sometimes I see centers doing CT scans and other types of scans. Is MRI is the gold standard?
So for the abdominal wall, CT scan is perfect.
Okay.
Quick,
Okay.
It's easy. You don't even have to use contrast, just oral contrast, and it's relatively inexpensive. It does involve radiation. But anything above the pelvic area, CT scan is great. For the pelvic area, CT scan is actually horrible to the point where we published our study, and if I can find the paper, I'll share it with you. Like something like 3/4 of the studies were misread or missed on CT scan. And here it is, I found it. Let me share this so you can see our data. So we have an MRI protocol for that.
Oh yes, I love your MRI. You sent that to me before. It was really helpful.
Let's see if I can find.
So, and to be clear, when you say CT for pelvic, this is when you're talking about more inguinal or femoral?
Yes, for pelvic, for CT for pelvic is much worse. So these are like representative pictures. It's a great paper that we wrote. And if you look at this, I think the next one's better. So if you look at this, here's a CT scan, right? Sensitivity, 25%.
Wow.
Negative predictive value, 4%. Accuracy, 27%. Really low number. And then MRI, 90%. Accuracy, 54%. So still not perfect, but much, much better than CT scan. And if you look at like the false negative rates for a CT, just look at this one, original CT scan report, false negative rate is 73%.
Wow.
True negative, only 3%. So if they say negative on a CT scan, the chances are you may have one if the symptoms and the exam are suggestive. So what we have is a hernia protocol that we have this MRI protocol. It's basically a non-contrast MRI. You just go there and then it's multiple MRIs in one. So it's a pelvic MRI. And then this is a radiology speak, so you can just print this out if you want. It's available on my website and on all my social medias. You can just look up MRI protocol. You can find it. But give this to your radiologist. They know how to interpret this language. But basically, it's a MRI, no contrast, and then a second MRI at the same time with the patient under Valsalva. And that will dramatically improve the catchment of an occult or a small inguinal hernia, whereas CT scan, like I showed, really horrible numbers for pelvis. So if you have symptoms and a history which is suggestive, that's number one. If you have a physical exam to support that, that's number two. And then for to confirm it, if you have to, if you get like an ultrasound or CT, ultrasound is actually better than CT for the pelvis. If you get a CT and it's negative, but you still have suspicion, you should get MRI. If you have an ultrasound, that's 50-50. It's not like as bad as CT, but it's still 50-50. If it shows an ultrasound shows a hernia, you have a hernia. If it doesn't show a hernia, you have a 50% chance to have a hernia. So you go over again to MRI. So that's kind of the way that we go about it, which is I go straight to MRI, but I mean MRIs are expensive, so I understand that. But a good CT, a good ultrasonographer is very helpful. But a bad ultrasonographer,
Not so
of which
good.
there's a lot, unfortunately, people just don't do ultrasounds anymore. So I have this old radiologist who I hope never retires unless I retire first, who called me and says, "Hey, I heard you do hernias. I love hernias too, and I do hernia ultrasounds." I was like, "What? That's awesome." So if I send it to him and he says no hernia, there's usually no hernia. But if I send it to our local hospital, where usually the tech does it, the radiologist is nowhere around, they read it like hours later, then it's usually not as accurate, unfortunately.
Yes, I have so many segues of questions from all this, because this is the stuff, this is what the people want to know. This is all the stuff that we don't have, we're not privy to know a lot of times how the back end of this works or the front end of this works. So MRI obviously for pelvic, but if it's abdominal, is it still accurate for abdominal? So could it be that someone gets, you see a lot of times MRI for pelvic abdominal, for both, and that would be okay, or would you recommend they get CT?
MRI, yeah, MRI for abdomen, it's usually not helpful.
Oh, okay.
CT is much better because
Okay.
the layers are much easier to interpret. If someone absolutely doesn't want the radiation, you can get up to MRI. It's just much more difficult to read MRIs in general. So limit it for the pelvis. But yeah, it's what I see most is people saying, "Oh, I know I don't have I've had this pain for so many years. No one can figure it out. All my studies are negative." And I'm like, "Send me your studies. I will reread them, because the reality is it's probably been misread."
Right.
So I just want to reiterate, imaging is a good adjunct, but the most important is your history, because those specific questions are to tease out are perfect, and then the exam, and then imaging is there to support your suspicion. But if you think for sure there's a hernia and the imaging says no, either reread the imaging or get a better imaging.
Yeah, and you bring up another point. It also depends who reads it. So even if you get the right test, like you said, a CT for abdomen, a MRI, you do ultrasounds, if all of them are not good at reading, they basically either the radiologist and or the physician that's looking at it, you're another physician, you're also going to run into problems. I remember distinctly working with this one hernia surgeon in my area, who unfortunately has left and moved away, which is so sad. But she would put up a CT and say, "Oh, they missed that hernia, that hernia, that hernia." And she said, "This person's been having these problems for years, and multiple tests saying they don't have hernias." And she looked at it for a second and said, "Yep, there they are."
I had a lady who was I think she was a stewardess, to the point where she had to quit her job, and so much pain. And she brought me like a whole stack of all her CDs of all her images. And there was one from like 13 years ago that showed the hernia. And she's like, "Oh my God, you read that? Wait, what date is that?" And I was like, 1997 or something. And she passed out, because basically she could have been diagnosed 13 years ago, but she had negative. The radiologist says negative because there's no cancer or there's no variances, like things they usually look for. And then the doctors read the report. They don't look at the imaging.
Absolutely, right.
So that false report gets perpetuated from doctor to doctor to doctor. And they say, "Oh, I've seen so many doctors. They all say I don't have anything." And I said, "Did they ever look at your imaging themselves?" "No, I gave it to them, but they kind of tossed it away. They just looked at the report."
Yep.
And it's a problem. Like I said, we need to touch our patients more, and then double, triple check all the studies that are done.
Yes, exactly. It's fascinating to watch how many places where either, again, from history or palpation or just general understanding of the symptoms, they're getting missed already. And then if they even happen to get scans or imaging of any sort, they still can get missed. So there's multiple places. Yeah. And so you do offer service where people can't connect with you even away, like wherever they are in the world, right? And they send in their scans, or you tell them what to do and how to get the best consult from you.
Yeah, as a child, I always liked solving puzzles. And so this to me is like puzzle solving. So I just tell people, I understand you can't come to Beverly Hills, you live far away. I understand that. You have family, whatever. Just send me your stuff. So I offer online consultation. My office handles it. I get like a manila envelope full of CDs and CT scans and op reports and prior studies. And they send me pictures and so on. And I kind of go through it like a forensics type thing. And I try and figure out why they have symptoms, why they have pain. And I write them a really long email that describes like all my findings, all what I think should be the next steps. If they wish to then come to see me because I can help them, that's great. If they want to stay near their home, then I'll say like, okay, I know Dr. So-and-so here, or let me contact this other surgeon. We're all connected. It's a small family of hernia surgeons. And then they take my email, they share it with them so that they're not blown off. Sometimes they get blown off. No, there's nothing here. And then like, sometimes I even send them a PowerPoint with a picture, like here's the hernia and here's the fat and all that. So it's very helpful. It helps patients, and I enjoy the mental gymnastics to do that.
Yeah, I love it. And you solve so many cases. If you follow all the social media that you put out, there's so many wonderful messages and letters of people saying, I've waited years and years and finally found someone that could help me. So you're really doing incredible work. And that's why it's so exciting to have you here.
I mean, who would think for hernias, right?
Right.
I could understand cancer or these kind of like, but I didn't think this would be my destiny, but to be able to help so many people just from like fixing or finding hernias, I think has been very gratifying. And I'm still shocked that that's like, it affects people so much, but you've seen people with debilitating pain. They can barely walk, some of them. I had one patient who came in. She's broken all records for me. 21 years of chronic pain, and she had a hernia. She had her uterus taken out. She had her appendix taken out. Gallbladder was taken out. She had ovaries taken out. Like tons of surgery. Still couldn't figure out why she had pain. And then I saw her post-op, and her son started crying. And so what happened? He said, I had forgotten what it was like for my mom not to limp when she was walking. I mean, I get emotional just saying the story. He cried in my office because my mom, his mom was walking without a limp. He had forgotten what she looked like, walking like a normal person. I mean,
what type of hernia did she have?
She had just a regular inguinal hernia.
Inguinal hernia, and it was just. Is it that it's also, the other thing is, I have heard through, I've been doing this 20 years now. It seems like there's also, because you said there's not even research for women, research papers aren't out there. Is there some sort of, is it that women don't get the same treatment or don't get the same assessments or aren't assumed to have hernias? Would that be accurate to say? Okay.
Absolutely. I can't share the data with you officially yet because it's being, it's almost being published, but we specifically looked at women because no one has looked at women. And what we found was, compared to men, women were significantly delayed in their diagnosis for hernias by over a year of symptoms. And what's horrible is they were more likely to be on opioids. When they come in to see me, they're already on some type of narcotic. Yeah. And that was a shocker. But the story is that they're told, there's nothing wrong with you. It's all in your head. Why? Because women have a much narrower inguinal canal than men. Men have blood vessels in the vas going down, muscle going down to their testicle. Women don't have a testicle. All they have is a round ligament. So, if you have a hole this big versus this big to start with, when you get a hernia going through it, it's much more visible in men. And surgeons are trained to see a visible, reducible hernia before they call it a hernia. Like I joke and I say the hernia needs to slap them in the face before they'll call it a hernia. Whereas in women, they're more likely to have occult hernias, which is why they present with pain and men present with a bulge. So men have a bulge, they go see a doctor. Women have pain and they go see a doctor, and they're told, the men are told you have a hernia, women are told you have chronic pelvic pain. And that's just like it means you have to live with it for the rest of your life because there's no treatment for it. And a large proportion of that are inguinal hernias. So,
I'm so glad we're having this conversation. This is, I mean, I'm taking a moment. I'm like, this needs to be, I mean, blasted. I'm so glad we're blasting this out there because it is so important and people suffer for so many years. And it is disproportionate in terms of gender. And it's something that, like you said, even the symptoms are different and the research is on men. So again, you're not even getting research on what's happening with women. So it's
considered a male disease, but I feel it's more like heart disease, where women were shown to be dying of heart disease because they have chest pain different than men. Oh, must be your breastbone or you're having reflux, and they're actually having angina, whereas men are taken straight to the cardiac cath lab. And then now there's this whole thing about women's chest pain is different than men's chest pain. So I think we're like the angina for women, for hernias, which is they have the same disease process, but the symptoms and the presentation are very different.
Yes. And I love that you have that paper on that. I'm going to note that and look at that. Is that out? The one with the female, the symptoms, is that one out yet?
No, we're presenting the data officially in September in New York, which I think will be canceled. We'll see. And then we're hoping to have it published soon. And we're actually using that data to come up with like a scoring system. So you go through and ask a bunch of questions based on different symptoms that I use every day. It's like a questionnaire that I already use. And then based on that, you can kind of predict the chance that an inguinal hernia repair will cure the symptoms.
This is great information. Awesome. And by the way, that's what I'm seeing, all these things saying, great information, fantastic information, incredibly helpful, informative, great information. This is exactly why I joined this group. As a doc, I have learned more here than a week of surgery. Great info.
Yay.
So we're getting all sorts of awesome comments. So a few other questions came up from what you're talking about. One of them is let's define, I know sometimes the word occult gets thrown out there. What does occult hernia mean and how does this apply here?
Occult, at least my definition, there's been a bunch of different definitions. So occult hernia is one that's not physically visible, but is symptomatic. So in women, it's usually a groin hernia that is very painful, maybe even be tender. To the typical examination, there's no bulge, and if you feel it, you don't feel anything. I would feel with my fingers, because I do so many of them, I feel like a slight fullness or swelling along the inguinal canal. And if you fall, like I said, you go ASIS to pubic tubercle. So if you fall along that line, you can feel this diagonal kind of finger-like swelling. And then on imaging, they have the hernia. So there's usually fat in there. It's almost never intestine. It's never big enough for that. Right. And then you fix the hernia and the symptoms go away. So that's an occult hernia, which is a symptomatic hernia that's not physically visible.
Yeah, and do you sometimes find that, like you said, everything checks out, but you're not seeing it on MRI, so that's when you do the surgery and go, aha, in fact, it was an occult hernia. That's basically how you find it on surgery, or?
I usually find them on imaging. I don't like to take surgery without a diagnosis.
Okay.
Because you can have other reasons for the similar groin pain, like a hip labral tear can mimic some of the similar symptoms. It's kind of deeper, but same area. They tend to have more of a gait disorder, and they don't have a lot of the vaginal symptoms. But you know, you have to rule out hip in a lot of patients. Rarely like a L1 or L2 disc disease can cause similar symptoms. There's some rare diseases, some autoimmune diseases that can cause like sacroiliitis can cause groin pain. So you have to be, I mean, if you're a hammer, everything looks like a nail. So to me, everything's a hernia until proven otherwise. But I do try and have an open mind because you don't want to operate on people.
Right. It makes sense. I'm surprised at how many people have sacroiliitis that gets missed too. Because that's something that is diagnosed younger in people, and they're just not, they're not even seen for it or addressed. So yeah, it's different than just having, a lot of people say SI pain and they say SI joint dysfunction, but that is a true diagnosis.
Yes,
Yeah.
absolutely. Yeah.
So important. Okay, so some of the other questions. Gosh, this is awesome. There's so many great questions going on.
Fun. We should do this every week, Tracy.
We should. I think we're onto something here. Okay, I'm not complaining. I'm open to it. Let's see here. Okay. There's one question I saw. Oh, so when Alana was asking, will an occult hernia always be seen on ultrasound?
No. So ultrasound, if it's seen, they have it. But if it's not seen, 50% of the time, that's an incorrect report.
Okay, that's right. Yeah. And by the way, Alana, I don't know if you saw.
Always, it's like 96% seen on MRI, though.
Okay. So we did talk about that before. So Alana, so if you missed that, we went over MRI versus CT versus ultrasound, and really fascinating data that basically you kind of almost need a mix of different things depending on what you're suspecting it could be. Yeah. Let's see here. Let me see. Lots of different questions. And as you know, as you can see, I have my own questions that come with this too.
Good.
So someone asked a great question. I'm looking for it. It was about a C-section. Oh, I know what it was. Something along the lines of they had a C-section and they think they have some sort of hernia. Now you hear about general surgeons like you who specialize in hernia surgery, and then we see plastic surgeons who deal with if someone wanted to get some form of a tummy tuck of abdominoplasty. Would a plastic surgeon who's doing abdominoplasty be actually trained typically to deal with a hernia as well? Or would they actually, because they deal with umbilical hernias, but if they had a different kind, let's say a lower abdominal or inguinal, they wouldn't necessarily be trained in that. They would need two separate surgeries or?
Usually not. So most plastic surgeons are general surgeons by training, and then they get a subspecialty in plastic surgery.
Okay.
And so they should know how to do inguinal hernia. Most choose not to because they don't want to take on the liability of doing an inguinal hernia and the aftermath of it. So that belly button hernias are usually fine doing, but the groin hernias they usually do not do, although some do. In terms of C-section, so C-section itself is a transverse incision, and the muscle is also almost always cut transversely. So the incisional hernia rate from a C-section is very low. All the transverse incisions are very low. It's the up and down ones that have a higher infection rate. Hernia rate. So you can have an incisional hernia from a C-section. It's very uncommon. And a CT scan or MRI can show you that. What's important though is if it's a long C-section, sometimes they can catch the ilioinguinal or iliohypogastric nerves at the edges.
Yes.
So if they have pain, but it's more of a burning, hot poker pain, hypersensitivity, it's not positional, those are more likely a neuroma or injury like a scar tissue from the C-section entrapped an iliohypogastric or ilioinguinal nerve, especially if it radiates around to the lower back. And that is a different problem.
Right.
I treat those just because it's in the same realm, but it's a different problem and it's treatable, but it's not a hernia.
So actually, again, perfect segue because I had questions about, you hear about neuromas or some people who get hernia surgeries, one of the potential effects is that they would have pain after, and that's because of, like you said, ilioinguinal, genitofemoral, or iliohypogastric issues with those nerves. Yes. So I know some surgeons do preemptive neurectomies of some sort to prevent that pain, and others don't, and then they'll do like some sort of neurectomy or to deal with the neuroma after. Do you? What is the gold standard to do?
So those of us that deal with chronic pain are very against prophylactic neurectomies or preemptive neurectomies. It has a 5%, regardless of how you do it, it has a 5% neuroma complication rate.
Okay.
Best is to just look at the nerve, identify the nerve, and don't do anything to it. Leave it in its natural bed. The European Hernia Society guidelines and the International Hernia Society guidelines both recommend preservation of the nerves and not any preemptive neurectomies. So, and I'll tell you, you mess with the nerves, there's something about nerves we just don't understand yet. The nerves talk to each other, and it totally takes people off balance when you mess with their nerves. So I'm very much against any type of prophylactic or preemptive neurectomy. And even if they do need neurectomies for their chronic pain. Let's say it's been injured or it's
Yeah.
entrapped. Some surgeons advocate a triple neurectomy off the bat, whereas there's something called selective neurectomy. You just deal with the individual nerves. So I'm on that more conservative camp of selective neurectomies if needed.
And based on selective neurectomies, so someone's having intractable pain, it was after surgery there, or like you said, C-section or something, you would be doing a block, a local, like a abdominal block or a spinal block to figure out exactly what nerve would potentially work well for that. Is that correct?
Yes.
Yeah.
So if it's a huge neuroma, surgery is the only treatment for that, but most are not. Most, it's like they're entrapped or they're small neuroma or there's some type of early injury. So with those, you do blocks primarily to figure out or to confirm that that's the reason for their pain. So if their pain is 100% gone, then that nerve was the issue. Got it. And then I do not just diagnostic, but therapeutic blocks. So I add little steroids to it and long-term analgesia. And if their pain is gone for days to weeks, then great, let's do another block. And then it'll be another weeks to months. And then between 3 to 5 nerve blocks, their pain may be gone because the nerve has kind of healed itself. Whereas if their pain shoots back right up within 6 hours or 10 hours or one day, they are going to fail non-surgical treatment.
Yeah. And are the blocks local abdominally, or do you do like L1, L2, like getting the full?
Pain doctors do epidurals in the back. I think for specific nerve injuries, you have to go straight to the source where the injury is. And I do it. But yeah.
So you do more local. That makes sense. Okay. And so, all right, this is really helpful because I work with surgeons along the way who do a lot of that preemptive type stuff, prophylactic stuff in terms of neurectomies to prevent it. And I thought, wow, that sounds interesting, but it's good to know that actually that's not necessarily recommended and can
so this all came out because there was all this interest in chronic pain from mesh, and they're like, oh, well, they just cut the nerve so doesn't get caught in the mesh. So half those surgeons weren't even trained on how to do neurectomies. So they cut the nerve, but they don't actually hide it away from the mesh. So the nerve is still, now you have a cut end with the mesh, which is horrible. And then you still have like a 5% chance. And in women, the ilioinguinal nerve gives you sensation to your mons. You don't want to be numb on your mons. Like sexually, that's not a fun thing. For men, it's not as big of a deal if they have some scrotal numbness. So yeah, we don't advocate for that.
So out of curiosity, I think I already know the answer, but just for fun trivia, if anyone wants to play along, actually there's a pause, so you'd have to really pause because there's a delay here. But so genitofemoral, ilioinguinal, and iliohypogastric, what's the top one that you find is an issue if you do have to do a neurectomy?
Yeah, so ilioinguinal is the most commonly injured nerve, especially for open inguinals. Never an issue for laparoscopic, almost never. That's the genital. So for laparoscopic hernias, it's a genitofemoral nerve that can get caught in problems as number one. For the open inguinals, it's the ilioinguinal. And fortunately, we don't see a lot of genitofemoral nerves. Those are much more difficult to treat because they're smaller and more difficult to access because they're near so many critical structures and deep.
Yeah, makes sense. So I'm looking at lots of questions and I will do my best to come back around to them. So I don't want you to think that I'm ignoring you all here. I will definitely get back to you. But one of the other things that comes up a lot, and the glaring thing I have to ask about it, is mesh. You mentioned that, and I think that's also an important thing to ask about, is a lot of people are significantly scared to get hernia surgeries because they've heard about mesh or had mesh complications in the past or are just concerned about it.
Yeah.
Others feel that they'll see that there's a surgeon advertising meshless surgery. So come on in, you won't have to deal with mesh. Are there times, my understanding is there are times when you just have to have mesh, and it will depend on, again, what you're using and how you're doing it. And other times you may not, but I'd love to hear the delineation of all those things in terms of mesh.
Yes. So I must say that, well, for sure, our lives are very different as hernia surgeons since there has been a big social media and layperson's interest in mesh.
Yes.
The reason for that started with the pelvic mesh, and there may be some nefarious reasons why people have also had pelvic mesh complications. and it's now gone into the hernia world. So we actually have a paper that will be published in October, specifically looking at the effect of social media on our use of mesh.
Oh,
And
wow.
we have with patients and so on. But to be fair, hernia mesh is less of a problem globally than pelvic mesh, because we usually put it against muscle and not against pelvic floor, urethra, vagina. We don't put them there. So in general, the placement is not as complex, and removal is much easier to deal with. However, it is an implant. It does cause inflammation almost always. So all of that can cause chronic pain, and it can fold, it can wrinkle, it can entrap or impinge, it can erode. Those are all the complications of mesh. And then we're seeing more and more now actual physical systemic reactions to the implant product itself, almost like an allergic or immunogenic reaction, similar to what we saw with some of the breast implants in the past. So it's complicated. Most of us that are in the know are not overusing mesh as much as we used to. It used to be we wouldn't even think about it. And so everyone just got a mesh repair unless they specifically pushed us or asked for a non-mesh repair. And then there was certain places like the Shouldice Clinic in Toronto that always did Shouldice, which is a tissue-based repair. And so foundationally, they had already branded themselves as a non-mesh repair. They use mesh. I mean, there are situations where they have to use mesh, but it's like in the single digits percentage-wise. It's not what they cater to. So I think we overuse mesh, and I'll if I can share with you one of my most favorite analogies that I came up with.
Please do.
So the problem of overusing mesh is every study has been shown to have better outcomes with mesh. In other words, if you have a hernia with mesh and a hernia without mesh, the one with mesh always has less recurrence rates, easier recovery, etc. And the ones with tissue repair only, higher recurrence rate, more acute pain, and so on. And no one used to study like long-term pain. It was always acute pain. So the first like couple weeks to 3 months. So that's a flawed study. If I can use this analogy, if you need to go from point A to B, and your options are walking or taking your car, it's always faster to go by car. Always. Whether it's 1 block or it's 10 miles.
Maybe not in LA though, usually.
Maybe not in LA. Okay, good.
Okay, all right, continue on.
True. But it's always faster to go by car. Now, car has risks. It's bad for the environment. You don't get any exercise. You have to pay for gas and so on. But if you do a study, it's always going to be faster. Does that mean you should drive everywhere? No. If you have to drive to if you have to go to your neighbor's house, you walk, right? If you have to get groceries, you take a car. So there's times when you should use mesh, and there are times when you shouldn't use mesh. So like for umbilical hernias, even for a 0.5 centimeter umbilical hernia, the studies show you it's better if you use mesh.
Really? Because
Yeah.
I do hear people say, well, my surgeon was able to say it was so small that I didn't even need mesh, but that's not necessarily better per se.
So correct. So from a recurrence standpoint,
Yeah.
if you've already recurred and they go back, oh, it's so small, just put a couple stitches in it, probably that's going to fail more likely than if you put mesh in. That's a fact.
Okay.
But like, what's the risk benefit ratio? You know, if you're telling me I have a 5% recurrence rate, that means 95% chance I'll be fine. Don't put mesh in me, you know?
Yeah.
But if it's a 50% recurrence rate, okay, then maybe or 60%, then yeah, I'll take the chance with my mesh. So it's very dependent on patients' morbidities, you know, how big the size of the hernia is, if they've failed a hernia repair before, all those factors. And so like if you have Ehlers-Danlos, I'm sorry, but there's no way Ehlers-Danlos will ever get a non-mesh repair. It's just not possible, because that issue is like very abnormal from a collagen standpoint. You can sew it as much as you want, it'll always fail. So I understand the mesh dilemma. I take out a lot of mesh. I'm very, very in tune with patients' concerns with mesh, but I'm not an anti-mesher. I don't think mesh should be banned. I don't think mesh kills people as a general statement. Have there been people who have died from complications of any surgery, including mesh surgery? Yes. Have there been surgeons who have failed to appropriately address people's problems with mesh? Yes. Should it be banned as a rule? No, because there's a lot of surgery I cannot do in people without mesh. Will I maximize how much non-mesh related surgery I can offer someone without significantly altering their quality of life? Absolutely. And I think the benefit of having so much social media and voices out there that are opening our eyes, our surgeon eyes, to, as a surgeon, we were arguing about, 1% versus 0.5% recurrence, 0.5% versus 0.25% recurrence. Like, how can we get that number lower, lower, lower? As if it's like the Olympics. But, for a patient, they don't care if it's 1% or 0.5%, they'll take, but then no one was looking that the chronic pain rate was 12% or 20%, 30%. So, it's our community has failed in that respect early on. Mm-hmm. We went to one extreme, and I think we're slowly coming back to not overusing mesh as much. What I must say, though, is there are people that are taking advantage of these patients and telling them that they're like meshless surgeons and all mesh is bad. Yep. And any surgeon that puts mesh in is evil and doesn't care about you. And that's not safe or healthy either. And you should really, like any surgery, get multiple opinions and figure out what your options are.
And I think it goes to this whole idea, no matter what within pelvic health or really any kind of medicine, those that do a lot of surgeries and they've been doing it for years and you can see that their outcomes are good, they're going to just consistently have better protocols in place and all that. If someone is flipping burgers and once a week doing hernia surgeries, they're probably not going to have as good of an outcome. So you want to go to someone like you who you specialize, this is what you do, and you look and analyze the data and you're doing the research. I mean, you're consistently looking at all this.
Yeah, but let me just clarify, because there's a question on your site.
Oh, sure.
Yes, all the studies show even a 0.5 centimeter belly button hernia has a better outcome with mesh. But like for me, and even in the, I think our European Hernia Society meeting also guidelines include up to a 1.2 to 1.5 centimeter hernia. The difference between mesh and non-mesh is not that much. It's still better with mesh, but my cutoff is about 1.5 centimeters. So at about 1.5 centimeters, I offer non-mesh repair. Understanding that the recurrence rate's slightly higher, but you haven't burned a lot of bridges. But like a 4 centimeter hernia, I would never do tissue repair for the standard patient. Now there are patients that can't get mesh or whatever. But as a standard, like a 4 centimeter would need a mesh repair.
Got it. So one of the questions too, Alana was coming back to she said, sorry to bring this up again. And I see you said sorry again. She made a comment, she's Canadian. She's going to say sorry a lot. Sorry to bring this up again, but is there evidence to support the 50% ultrasound? There are people I think clinically have strong suspicion of inguinal hernia, but physicians not willing to move to MRI to rule it out.
Yes.
Yeah.
Look at my paper. Let me see if I can bring it up for you.
Yeah.
Just Google Towfigh imaging. There's 2 papers. The first paper is the one that looked at ultrasound, CT, and MRI. And it showed the exact numbers of the false negative rates of ultrasound versus CT versus MRI for occult hernias, which is most applicable to women's hernias, but in general, it was for all. It wasn't, we didn't do it just for women, but yeah, that paper was published, I want to say 2016. Yeah.
Awesome. So one of the questions that comes up for us, a lot of us that are in the pelvic health, pelvic PT and OT field is because we do so much touching and palpation, some people get scared. Okay, so this person had a surgery, whether it was 12 weeks ago or 3 years ago, and they have mesh. How much are we allowed to be relatively aggressive around the area, or do we have to watch out for anything? A lot of people ask those questions. I wanted to get it from you as the surgeon.
that mesh is stuck within 3 days. You cannot disrupt a hernia repair with any amount of deep tissue work or manipulation. So do whatever
Okay.
you do.
All right. So elbows and everything we can.
Yeah, that's what they need.
Okay, we don't normally do that, but okay, good to know. That's great to know, because there are so many patients come in and say, I had this and I'm really worried about you touching there. I have
Yeah.
mesh and I'm afraid it may hurt something.
Yeah, tell them I said it's okay.
Okay, all right, good to know. And then actually one of the questions that came up too in one of the groups was, is there a protocol? So for example, there's an ACL protocol after surgery or something. Do you have a specific protocol that you give to people? So then the first week, don't do this, don't do that.
Okay, that's a great question. Up until recently, we had no protocol.
Really?
Yeah, I mean, everyone would say, okay, so I had my surgery. Like if I had knee surgery, there was this whole pelvic, this whole physical therapy protocol that my orthopedic surgeon wants me to follow. Should I do physical therapy now? And we're kind of like, I mean, sure. Okay, we actually have this now. Let me share it with you.
This is so exciting.
You're gonna love this.
Everyone, you're seeing it here. Say first. I don't know.
This is live. This is very fresh off the
Look at
press.
this.
So this is the AHSQC. AHS is the America's Hernia Society. We deal with all the Americas, Northern, Central, and South America. And we have a quality collaborative. It's basically a national database where I'm here somewhere where we plug in all of our hernia patients in here and we follow them for their lifetime. So this is the only database in the US that's hernia based.
Okay.
You're going to go under patients. There is an abdominal core rehab protocol in here.
I can't believe this.
Yes. And it's free and you can print it out. So if you go to information for patients, there's actually one for physical therapists too, believe it or not. So let's make sure this is, oh no, this is not it. Sorry.
Got us all excited.
Patients. Here it is, rehab. Okay, then you press okay. Okay, so here's the rehab. There's a patient guide, physical therapist guide, and an in-hospital guide for the patients and their physical therapists. So the patient guide has the best pictures, and I now give this to all my patients. So it's basically, I'm going to go to before surgery,
this is so great.
in hospital, and after surgery. Most surgeons agree to these things. So this says like how to do self-care and make sure you're doing diaphragmatic breathing and you've got good posture, your pelvic floor, and then different stretches to get you kind of prehabilitated for surgery, safe ways to stretch. This was developed with Dr. Ben Paulus from Vanderbilt, who's now at Ohio State, and he worked with his physical therapy and pelvic floor teams. And then they validated it. So this is very familiar to all of you, not as much to us, but these are all like ankle pumps and heel raises. This is just what we call prehabilitation. Pelvic floor contraction. Okay, day of surgery. This is mostly abdominal wall hernias. You know, bring your binder, breathe with movement, sit up in a chair for all your meals, walk 3 times a day for 5 minutes, etc. And you can do all these different exercises in the hospital. This is key. After surgery, wear your binder. Here's the different walking programs, lifting precautions, and then different stretches. These have already been talked about. Here's like kind of different activity levels you should follow. And then walking programs, how much you can lift, and then different types of stretching. Tensor fasciolateral stretch was actually very important. It just goes on. Then in weeks 4 to 8, where you can ratchet it up a little bit, leg raises, a lot of kind of yoga movements, stretches, core, clamshells. Dr. Paulus at Ohio State's a big fan of planks. He's like, everyone should be doing planks.
Which is exciting because in a lot of worlds, whether it's abdominal surgery or postpartum stuff, there's a lot of actually negative things about that. Don't ever do a plank again. So it's actually good because I think that it really depends on the person. They can absolutely.
Well, they measured it. He measured the tension, how to get out of the car like safely and all that. So this sit-ups, curl-ups, like leg lifts, these are all things that people, here's the plank.
Look at that.
they were
Yep.
telling you not to do it. I mean, and then here's like, so this is awesome.
Yep.
And then the physical therapist guide one is not as fun because there's no pictures, but it basically talks to you about what is safe and what's not. And I highly recommend
Great.
you just take this, print it out. It's free to anyone, any of the public. It's on the main HSQC website under patients. And
That's fantastic. And by
there's
the way,
an
we
app.
can put the link. We can put the links in Pelvic Guru and the GFAM pages or the groups.
Yes, ahsqc.org, and there's an app which has the same
Ooh,
information on it, which is
nice.
awesome. Yeah.
Yeah, this is wonderful just to even have these resources because they're, it's kind of the Wild West, I think, in a lot of these things. It's like everyone's just doing their own thing and figuring it out, but it's really nice to have some standards. And like you said, this has actually been validated in terms of things that are safe.
Yeah.
Look good. So yeah, everyone's saying this is great. And brilliant resource. What is, what was the doctor's name?
Poulose. He is now head of the Center for Abdominal Core Health at Ohio State. He became chairman there.
Fantastic. Awesome.
Yeah.
So this is what's going to happen now. I think we really, without me even looking much at my page, I think I've covered almost every question that was on the list. We have different people that wrote in about their specific kinds of cases. And we have questions that are all throughout here on, in the group. So what I would love to do is to handle some of the questions and maybe go over cases depending on time. But then the other thing is I just would love for you to give I always like to do a takeaway. So regarding the world of hernias, if there's one thing you wish everyone knew from your vantage point, what would it be, or what would you love to know for everyone to know from a takeaway?
It's all in the history. Okay. It's all in the history. If I could say that over and over and over again, people mistrust the exam and the imaging and all that. It's all in the history. Everything else is secondary. So ask good questions, and soon we will have a great 50 validated 50 questions for hernias. But it's, you know what, in fact, if you go on my website, there's what we have was called a Hernia Health Questionnaire. Let me see.
Oh, does that have the questions on there? I've been on your site before, but I can't remember seeing that. So that's good.
Okay. Let me.
And you are at you own the Beverly Hills Hernia Center.
Yeah. Let me share my screen again. So let's see. So interesting. Okay. So if you go on my website and you go under for patients, for the consultation visit, it includes my questionnaire because everyone needs to fill that out. And it's basically a downloadable, where is the questionnaire? Here it is, downloadable form. And basically if you go to it, you can fill it out or whatever, but the questions, here's the Hernia Health Questionnaire. So if you go on to it, the first page is mostly for risk factors like smokers or BMI, pregnancy history, all these other risk factors, family history. But this is the key. These are the questions you need to ask. Do they have, so where the type of pain and location, that's obvious. But here is important, this thing right here. Do you have any discomfort from standing, sitting, coughing, laughing, sneezing, intercourse, straining? Sometimes the pain lingers after straining. Stairs, getting in and out of bed, out of a car, bending, crossing legs. Is it better when you're lying flat? That's a really good one. Is it worse at the end of the day? And in women, is it worse during their periods? These are high yield questions. And we're coming out with a score pretty soon, like an app that will have like a scoring system. But, you know, this is key. It's not too many questions.
Yeah, and it's also important for people to remember that someone can have two of those that are positive and have a different diagnosis too. So this is a guide, but it's not like, aha, you definitely have a hernia. That's the only thing it can be. But this is really highly suspecting of it potentially. But again, you want to look at other factors as well. We
just want people to think, can it be a hernia? And at least start that process. Too often, they say, oh, well, women don't get hernias. There's no obvious bulge, and therefore there's no hernia. Totally false.
Right.
And then they get into that whole kind of chronic pelvic pain, ovarian cyst, endometriosis, adenomyosis, vulvodynia, all those different diagnoses. Pudendal neuralgia, that one kills me so much. I mean, how could the world have so much pudendal neuralgia? It's like such a rare problem.
Well, I teach a 2-day course on pudendal neuralgia, and it's interesting because there is a intersection of true pudendal issues. But again, you have to do so much. Pudendal is a label. So then we got to figure out, okay, is it actually, like you said, really the pudendal nerve, or is it something else that's mimicking all of these symptoms that were supposed to be diagnostic for it? We know is now it's basically a starting point, but it's absolutely, like you said, a lot of times this is why I end up sending for hernias and other things, because it's simply, like you said, it's not always pudendal neuralgia. It just isn't.
So for your pelvic floor specialist,
yeah,
inguinal hernias can cause pelvic floor spasm.
Yep.
So if it's an occult inguinal hernia, you don't know, but they present with pelvic floor spasm, highly tense on pelvic floor exam, and then they're supposed to undergo pelvic floor PT, right? That's a treatment for pelvic floor spasm, if it's primary, but not if it's secondary. Right. And then what happens is, if it's a hernia causing the pelvic floor spasm, they come to you, you initiate your physical therapy. They hate it because it's so painful, and they actually get worse. Like, it hurts them more. They don't get better because it's not a primary pelvic floor dysfunction. They actually have a secondary pelvic floor spasm due to the primary problem, which is the hernia. You fix the hernia, you send them back to their physical therapist, no more pelvic floor spasm. But also other pelvic floor spasm symptoms can come on board, such as pudendal neuralgia symptoms, right? Because the nerves run through the pelvic floor. Right. Also, severe urinary frequency, like 10 times a night they'll urinate. Related to the hernia, but that wasn't diagnosed yet. And then also painful intercourse.
And then what happens is they get treated for interstitial cystitis, pudendal neuralgia, all these other things dancing around it, when we really, this is why, again, like you going to your point, history and really being a good diagnostician and a problem solver really helps. And this has been my mission too. It's like, we can't just stop and say, oh, okay, they have these symptoms. We have to look at all these.
Can we do like a virtual
high five? Yes.
I know. Oh my God, you're like talking to me as if like me talking to me. I love this.
No, me talking to me, talking to me. Yeah. It's something that once you get it and the light bulb's gone, it's like, it's so important to make sure we're doing diagnostics. So thank you so much.
Thank you.
All right. So let's see. I'm trying to look and see what questions, and that was a great takeaway for sure.
So many comments. I love this.
I know. I wasn't expecting all these comments, and this is why I apologize if we're not trying to ignore you. I'm certainly, what would be helpful at this point is if you feel like, I feel like this is a test or something. If you feel like your answers have still not been, or your questions have still not been answered at this time, please, if there's any burning questions left, go ahead and drop them again to make sure that we didn't miss them. One of the questions I did like that was here that I think would be very helpful is, someone said, what if they had some form of, someone had a mesh surgery, some sort of, I think it was inguinal, maybe umbilical, and then they're pregnant. Are there any problems with that, with pregnancy post umbilical mesh repair?
Oh, after repair. Can be. So we don't like to repair umbilical hernias until you're done with your pregnancy.
Okay.
Same with diastases. The reason for that is mesh does not stretch.
Okay.
So if you have a mesh repair, the risk of chronic pain during pregnancy, because your whole belly is trying to stretch and there's this one area where the mesh is that doesn't stretch, that can cause chronic pain. And then if you do a tissue repair, those tend to recur after pregnancy, during pregnancy, after pregnancy, they like pop because of the abdominal pressure. So we prefer just not to go down that route. If they have an umbilical hernia, still want to have children, and it's not killing them, then usually we just delay that until after they're done with, so they have to be done with pregnancy and 3 months after they're done with breastfeeding, because our hormones that keep the muscles stretched out, the progesterone, is still high while you're breastfeeding. So you have to be 3 months off breastfeeding too before we recommend any type of hernia repair.
Unless there's some form of, obviously, some emergent stimulation or something. Yeah. But So yeah, it sounds like this, it could be one of those things where they didn't know they were going to be pregnant again, and suddenly you find yourself in a situation. So
Yeah, I mean, it's not 100% that they get chronic pain, but
okay,
you know,
but it's definitely not ideal.
yeah.
Oh, one of the questions that came up, which is a great question, Amy, I'm so glad you asked this, about good referrals, because you had a site or information about if someone wants to find a really good hernia surgeon in their area.
Yeah.
Again, I would highly recommend consults with Dr. Towfigh too, in terms of just
So of course, I do have, I'm very present on social media. I try to answer as much as I can. And I offer in-person telehealth or telehealth. And I also offer what's called online consultation, which honestly, you get the biggest bang for your buck with the online, because you kind of get me for life, because you just email me whatever you want. But let me show you.
good to know.
I made this site called Hernia Talk, and it's basically a free discussion forum for patients. There's a handful of us surgeons, about 10 surgeons that are on it.
So
And
awesome.
it's pretty active, lots of questions. We have look at 125 more pages of questions. It's searchable. So let's say you want a surgeon in India, or a surgeon in Canada, or you want to look about a certain type of mesh discussion, you can just put in the search and find. So when I tell my patients that contact me, oh, who do you recommend in Alabama? Well, unfortunately, no one, but you can you can go on this website and see if anyone's discussed Alabama or like Texas. There's also not that many in Texas. And then the other one, which may be good, is just the actual AHS Society. That's the main site for the American Hernia Society. We have a find a surgeon. If you go under patients again, find a surgeon. These are not vetted surgeons. They're just members of the American Hernia Society. But if you just put in like your city or your state, like just put in, I don't know, California, then it'll list all the AHS members that are in California. Okay. So it's a resource that's available to look for surgeons near you or near your patient. I personally think Hernia Talk's a little bit better, because those are all vetted doctors. Either I know them or someone's been to that doctor and they write about them.
Awesome. And by the way, I know I talked to you about this a while back, because we have our directory too. The pelvicguru.com directory is multidisciplinary. And actually, we're trying to do some things with endometriosis surgeons that are really specialists, excision specialists. We want to get, like you said, vetted people that are surgeons that are really serving people at the highest level. So I will be talking with you about how we can even add some of these names at pelvicguru.com.
Sure. Yeah.
Okay, cool. Let's see. So there were questions about, so Howard, you asked this earlier, so let's see if we can answer this for you. What symptoms are caused by spermatic cord lipomas? So can it cause a sensation of heaviness or dropping down? Should a cord lipoma only be removed if it is attached by a narrow stalk or pedicle? In terms of postoperative neuralgias or risks? Oh, he's saying also in someone with metabolic syndrome and central obesity, can this give an appearance of cord lipoma even if one is not present?
So there's a normal amount of fat that goes with the spermatic cord. We don't consider that a lipoma. A lipoma is very distinct on ultrasound, separate from the normal fat or any imaging, but usually people get ultrasounds. Most spermatic cord lipomas, the fat of the lipoma originates retroperitoneally from the abdomen. So, and therefore there's a hernia, that whole thing. And therefore you have symptoms related to the hernia, but you're seeing the lipoma. In some situations, there's a lipoma with no hernia. That's very, very uncommon. And the symptoms from a lipoma are either none, or it's like a heaviness or like a fullness. Sometimes like they may call it testicular pain. It's not really testicular pain. It's really above the testicle, but people say it's testicular. But there should be no symptoms related to activity or function, a sexual function. There should be no symptoms related to a lipoma from that. You can take it out, but we usually don't touch lipomas unless there's a hernia associated with.
Okay. Yeah. So hopefully that answers your question, Howard. Hope so. Someone said, John said, well, I guess I'm in trouble. I'm in Alabama.
Oh no.
Well, it's kind of like all these other things within the pelvic health specialty or abdominal health is that you sometimes do have to you may have to travel to find someone that's really.
Actually, I shouldn't have said this. There's a recent surgeon, Dr. Abhishek Parmar, Parmar at UAB.
Okay.
So maybe, I think he's the only resource there, Dr.
Okay.
Parmar.
It's a good start at least. But sometimes people do have to travel, unfortunately, just because when there's this specialized and you want to make sure you're going to someone really good, it's kind of just, there aren't going to be a lot of people around necessarily. Oh, John said, I will travel, no problem. Okay. So let's see. I'm trying to see if there's any other major questions that we haven't addressed. Yeah, this is fun. I'm telling you, we could be onto something here. Let's see.
This is awesome.
I know. Let's see. I think, so some was asking about, John was asking, I did see there are some natural type exercises with people having good experiences, but either I missed it or not there with a hernia. Bring up a question about testicles. I remember in one of your, I don't know if it was a social media post or something you once posted about if someone has testicular, if their testicles draw up, that's also a high sign. We didn't talk about that. Can you talk about testicles at all in terms of, especially with exercise? Men will say, I'm exercising and suddenly I feel my testicles draw up.
That's a hernia.
One.
Yeah.
That's a hernia.
So retracting testicle is often the sign of an occult hernia. So the spermatic cord, the hole through which the spermatic cord goes through, the inguinal ring, should only be wide enough to accommodate the contents of the spermatic cord. If the testicle goes up high enough, that implies that ring is too wide. At least the external ring is too wide. And so that's usually a sign of a hernia. Doesn't mean it has to be repaired, but a retractable testicle should be addressed. So two things about that. A retractable testicle should be seen by a urologist as well, because there's a higher risk of testicular cancer in those patients. Because so the testicle needs to remain in a cooler environment than the rest of your body, which is why there's the scrotum. It's outside the body and therefore cooler than inside the body. But when it retracts, it heats up. That's like late terms. And not only can it cause infertility, but it can also cause higher risk for testicular cancer. So orchiopexy, where they sew the testicle down so it doesn't retract up, is one thing, but usually the underlying problem is there's a hernia, and that's why it can so easily go back up into that hole.
Yeah, that's so important because, I've treated a lot of patients that have that as a symptom, and we treat it from a physical standpoint, but you always wonder, is there something else maybe underlying that's being missed? And you make a good point that it could be occult too, which makes it even harder to know.
Right. So orchiopexy alone may not be necessary. May not be adequate. Inguinal hernia alone may not be adequate. You have to do inguinal hernia and the orchiopexy at the same time. So you close up the hole and then you tack down the testicle to prevent it from, because the tendency is for it to want to go shorten and go back up.
Got it. That's great. So one of the questions too, Colleen was asking, when doing abdominal exercises, should we be watching for the size of the umbilical hernias? So or even, I guess you could say the same about any kind of inguinal bulging. So should we be looking for that?
Not really.
Okay.
Size is never a matter. If anything, smaller hernias may be more dangerous than larger hernias because they tend to incarcerate more.
Didn't know that. Another little point.
Yeah, so
Smaller
big hernias look worse. Smaller ones are more likely to get pinched or entrapped. So no, there's one study that showed that if the hernias have like a neck to it, and then it's like a lollipop, So if the neck is 1/3 the size of the hernia contents, the risk of it getting caught are higher.
Got it. So it definitely doesn't mean the larger one is the worst per se.
No.
I didn't know that.
No.
Learning things here. Let's see. There's a question about top few questions patients should ask when interviewing their surgeon for hernia repairs.
That's a good one.
I know.
That's a good one. Okay.
Yeah. Who was that? That was Erica. Look at you, Erica.
We just had a discussion about that on Twitter. So if you look up me and Dr. Barbara East, she goes by @HerniaGirl. BE is her initials, but @HerniaGirl on Twitter. She asked that question: what's the best? What are the top questions you should ask? Because how do you know if the doctor's good? So my personal bent is, if the surgeon, so all general surgeons are trained to do hernia surgery, and I don't want to discount the vast majority of hernias are done by general surgeons that are general. They do gallbladders, breast lumps, colon cancer, bowel obstructions, and hernias. So that's usually okay, but if you've got a complicated situation, or you want a non-mesh repair, or you want something but want to make sure you have a better outcome, you have to go to a specialist. Ask them the following. Number one, what percentage of your practice is hernias? I think it should be at least 50%. I'm 100%, but to be fair, that's like very, very rare. So I would say 50% means at least you have a special interest in hernias. The second question is, what types of hernia repairs do you offer? Do you offer open? Do you offer laparoscopic, robotic, and tissue repairs? If they say yes to all of that, then they know what they're talking about. If they only do open and not lap, if they only do lap and not, or robotic and not lap, or they don't offer tissue repairs, and that means they really don't offer you the full gamut. So it's like shopping in a mall that only has like, shoe stores, but you need like a whole outfit. So you want to, that's not really a specialist, which is why these surgeons that say we only do one type doesn't mean that they're necessarily better, because that may not be the right answer for you as a patient.
Got it. Yeah, that makes sense. So those are the big ones to ask. What percentage hernia do they do of hernia, and what types do they offer? What types of surgeries?
Yes.
Those are two big things. Okay, this is great. Amy's asking what, I think we may have said this, but just to clarify, what physical signs, symptoms, palpating should be screened for?
Yeah, so talking for abdominal wall or ventral, it's mostly like visual to see if there's a bulging, and then you see if it's tender and if it's reducible, because those imply different algorithms for how urgent the repair should be. And then you use imaging to actually measure the size to plan your surgery. For groin, that's a different algorithm. You go by symptoms, and then if there's a bulge along the inguinal canal or the femoral space, you have your answer. You barely need to examine them. But if you don't have the bulge, or it's not obvious, then you want to find a point between the anterior superior iliac spine and the pubic bone. Let's see if I can have that picture up again. And then based on that line, here it is. Based on that line, about 60-40 in between, you want to be able to feel along the inguinal canal. So here's the picture. So here's the right side of a patient, female. ASIS, anterior superior iliac spine, is somewhere here. Pubic tubercle is somewhere here. This is the line, which is the inguinal ligament. Notice it's not at the groin crease. It's some ways above it. And this is about 40% of the way, and that's about 60% of the way, maybe 65%. So if they have point tenderness here, or along this line, not all the way up, but along from about here to here, they'll have a fullness or a swelling that is distinct from the rest of the tissue. That is pretty diagnostic of an inguinal hernia. And I think up here we showed on examination point tenderness over the deep internal ring almost 100% of the time that you'll see that with an inguinal hernia.
And obviously for men, you can sometimes even get into that, space where for women, you can't really go into where that ring is.
Yeah, I mean, if you do a vaginal exam, you can maybe follow that space. No one does that. And in men, you can use the redundant scrotal skin to go into that space.
Yes.
Honestly, I don't even do that. It's so uncomfortable for the men.
Oh, okay, so you don't do that.
You can get it. If you have sensitive enough fingers, you can palpate it from the outside. But if it's very difficult, then I'll go through the scrotum and follow the spermatic cord up into the
Yep.
internal ring. Yeah.
So on that note, their whole like cough test, is that helping you? You don't even use that as a standard anymore?
I mean, that's classically how to do it. I just have them stand.
Okay.
I always examine them standing.
Standing. Okay.
That's the key is for any hernias, they always stand. Gravity will accentuate it. They don't need to cough or do anything like that. I mean, it's cute to do it, but I don't think it's necessary. And with COVID, you don't want them coughing anyway.
You don't want to encourage coughing.
No.
Yeah. Even with masks. Yeah, that's just true. All right. So Wilson has a question here. I had a double inguinal hernia repair in 1972 when I was 6 months old. I am now 48. I have been dealing with chronic pelvic pain for years. Many symptoms you list are familiar. Is it possible that the hernia has returned as an occult hernia? No one has ever seen a thing on scans, nor in a classic hernia test at a doc.
So if you had hernia repair 3 to 4 years or more, in your case, decades, and now you have new groin pain, it's a hernia unless it's a hernia recurrence until proven otherwise.
Really?
It's not a nerve problem. It's not a mesh problem. It's not a scar tissue issue. It's almost 100% it's a hernia recurrence. So
and that's what I've seen too. Even if the scans show no, like we talked about, there's issues with that. Yeah.
Yes, I had a patient who the scans didn't show it, and they legitimately didn't show it. But he's like, every time I get up, I can feel it, and when I'm up and about, I feel it. When I'm sitting, I'm okay. And so he needed to have a dynamic image, so either an ultrasound with Valsalva, or I got an MRI with Valsalva because the mesh distorts the ultrasound a little bit. And on MRI with Valsalva, you could see the hernia exposed.
Huh.
Yeah, he had like a little mesh plug, and it kind of like moved over, and the hernia came through. No other imaging would show it.
Yeah. Very cool. All right. So I think, it looks like we are at the end of questions. I don't know if you want to go over that one case or if we should just say, hey, we're at a good stopping point. There was one that was sent in to you I can pull up, but.
Whatever you wish. I'm open.
Really? All right. Well, let me see.
If I can't go anywhere anyway.
That's true. All right. So if I can pull it up quickly, we will go over this one. All right. So here we are. I don't know who this is late. This is an anonymous one, but we will go with the meat of it here. I just had it confirmed. I have an inguinal hernia. I'm 38. I have an almost 3-year-old. First labor was 35-hour labor that resulted in emergency C-section. I had an appendectomy 6 months prior to getting pregnant with my first. Could those surgeries have contributed to my hernia is question 1. Now want to try for baby 2, not sure how best to proceed. Do I have hernia surgery with mesh? I think you already answered some of this. Do I wait on surgery and get pregnant and hope for the best? Are there risks to pregnancy with an inguinal hernia? How can hernias affect labor? I was interested in a VBAC. Would that be possible? What stretches? Oh, that's into that. But yeah, that's an interesting thing. How does this affect pregnancy if she does have a hernia, inguinal hernia?
All super excellent questions. We don't have a lot of data to support a lot of what I say, but I'll tell you based on experience and some data, which is in general, if you have an inguinal hernia, you can safely undergo labor. You can safely have a pregnancy and undergo labor without a problem. It's very, very, very uncommon to have any inguinal hernia related complication during pregnancy. Fat can get stuck in there, but bowel will almost never get stuck in there, and chronic pain is low because your tissue become very flexible.
Okay.
If you have a painful groin hernia before pregnancy, you should be treated like any other patient, which is if there's indication for repair, get it repaired. If you're not that symptomatic, wait until you're done with pregnancies. Unlike belly button hernias, hernia surgery in the groin does not interfere with pregnancy or future need for C-section. So do whatever you have to do from an inguinal hernia standpoint. It will not be affected by future hernias, by future pregnancies or C-sections, and you should do whatever's, going to improve your quality of life.
Okay.
I hope is that clear?
Yeah, that's actually a good distinction to say the difference between an umbilical hernia versus inguinal in terms of even surgery before or after and pregnancy. Those are all really helpful things, I think. I know there's one other question in the messages, but I'm not able to find it, and I apologize to whoever sent that in. If I could find it, I would ask it quickly here, but I'm not seeing it. So yeah, let's see here.
These are all great questions.
I know it's just been great. It's been fantastic just to see everyone is asking all that. Maybe this is the person's, it seems to be muscular and concerned a hernia could be pressing on something causing spasms. I don't know what that's in reference to.
So we just already discussed that inguinal hernias can cause pelvic floor spasm.
Yep.
Some abdominal wall hernias can affect pelvic floor function, such as like rectocele, cystocele type symptoms can go away once you fix abdominal wall hernias. But also know for the groin, there's a lot of nerves in the area. So the fat or whatever is going through the hernia can be pressing on a nerve. So similar to inguinal hernias causing pelvic floor spasm and then recreating other pelvic floor dysfunction symptoms like urinary frequency or pudendal neuralgia type symptoms, the hernia can also press on, let's say, the ilioinguinal nerve, which is why a lot of people get inner thigh and pain to the inner thigh, into the vagina and around the lower back, or down to the testicle, is because it's really a nerve problem. But the nerve is fine. The nerve is totally fine. It's just being crushed by the herniation of content next door to it. And so it gives nerve symptoms. So many people go to their doctor and say, I have these symptoms. Oh, you have nerve entrapment. Mm-hmm. Well, people don't wake up with nerve entrapment. The nerve has to be entrapped by something, and it's usually the hernia. Now, if they've had someone stab them there, or they've had surgery in the area, scar tissue can entrap the nerves. But you don't just wake up one day with nerve entrapment. Yep. So all of those nerve entrapment patients have an occult inguinal hernia as their primary reason, and don't need nerve surgery or nerve pain. You know, they get sent to a pain doctor and they get all these nerve injections, and yep. Actually makes the pain worse in some ways.
And the fact is, a lot of times, I think one of the most overdiagnosed things is calling it nerve entrapment. I mean, that term gets used for so many things that are just truly a nerve irritation, inflammation.
Yes, irritation. Yeah.
Is this another high five moment?
High five. So on that note, it's inflammation, right? So what's the inflammation? Anti-inflammatories, ice pack. Just put an ice pack over the groin. Symptoms go away. It's such a great anti-inflammatory option for most simple inguinal hernias, just ice pack.
Right. And these, like you said, positional. But again, if the symptoms really affect quality of life at some point, it sounds like it may be helpful to get that taken care of.
Sure.
Let's see here. Ruth had asked earlier, so we're going back to Ruth. Are there any concerns about transverse abdominal nerves for any reason with this stuff?
Transverse abdominal nerves? So there's something called ACNES, abdominal cutaneous nerve entrapment syndrome.
Yes. And
that's not a common problem, but any weird abdominal pain along that Spigelian line again, the semilunar line, like right at the border of the rectus. Usually it's pinching pain recreated by either torso, like if you twist your torso, or engage.
Does that have a thoracic, there's something to do with the thoracic spine as well with that?
Yeah, it's often T11, T12, L1. It's usually like lower thoracic. Injection will cure the pain short term, and about half of those patients don't need surgery. They just need serial injections. But yeah, ACNES is the only like transverse nerve.
Got it. And then there was a clarification from Jennifer about, we talked to kind of danced around this, but I don't know that we specifically said this. So someone wants to do diastasis recti abdominis types of exercises post-baby, and they have umbilical hernia repair. Is there anything they should avoid, or can they just do everything as far as, again, just watching symptoms and issues, right? They're clear to do a true rehab program.
Yeah, they should be like normal. Yeah, all those transversus abdominis exercises are great.
Okay. And then there's another question about athletic pubalgia. Does the presence of pain with prolonged sitting and absence of hip pathology help the diagnostician localize a trouble spot to adductor longus or rectus muscle?
So athletic pubalgia is often not related to sitting, whereas inguinal hernia is. So those are people. So if you don't see a bulge, off, but you have groin pain or like pain in the inner thigh or pulling, it's often called athletic pubalgia or sports hernia.
Yeah.
Because, or they just call it a sports hernia because there's no bulging hernia.
Right.
They think everything else must be a sports hernia, but it's really an inguinal hernia. Those are what cause pain with sitting. So yes, hip, the differential for pain with sitting is usually hip disorder or inguinal hernia.
Inguinal. Okay.
Athletic pubalgia or sports hernias typically do not cause pain with sitting unless you have a tear with a nerve entrapped in it. And that's more of a burning, kind of very neuropathic hot poker type pain and not like a dull, boring pain that wraps around your lower back.
And Lindell's asking, can hernias have none or very little pain or symptoms?
Most of them have no symptoms.
So
yes.
People can walk around for years with a hernia and not have.
Yes.
Yeah.
So in men, they teach you in medical school that hernias are not painful. Not true, but very commonly in men it's not painful. It's mostly the bulge. In women, it's very commonly painful without a bulge. Okay. That's how we're different.
All right, we're going to do a final question. This is from Lauren. Lauren, you made the final cut here. My client had back surgery for suspected disc issue, had pain and numbness inner thigh before and continued on after surgery. Constant heaviness and groin sensation has never been addressed by physicians. Worse when standing for long periods of time. Would this be causing the back pain and numbness? Years of issues for my client.
The numbness is where?
The numbness had pain and numbness inner thigh before. So inner thigh numbness and then heaviness in groin and back pain. Right.
So that's probably either it can be inguinal hernia. The numbness is not normal, but the pain radiating to the inner thigh around the lower back can be inguinal hernia. Sacroiliitis should be in the differential because that can give lower back pain with pain in the groin into the inner thigh. And then like a high lumbar disc problem, like a L1 or L2 disc, which is not common, but it can happen, can give radiating pain with the numbness to the inner thigh. Now, if you have pain in the inner thigh, but down low, close to the knee, that's more obturator. So that can give you kind of inner groin pain from the obturator canal area. And then all hernias do give lower back pain, even umbilical hernias. So that may be where and then if you have a weird numbness or paresthesias in the inner thigh down, not up in the groin crease, but down towards the knee, that would be an obturator problem. So I would work up an inguinal or obturator hernia just to be complete.
Yeah, and remember too, so many things have multiple, someone comes into you with multiple conditions at the same time too. That's the other thing that's tricky, is it's not just, aha, we found one problem. Sometimes there can be several things going on and they each need to be addressed as well.
Yeah. Yeah.
So that's another
They're
piece
all related. Yeah.
Yeah. All right. Well, thank you all so much for joining. I know what we're going to do is leave this up, so I think it'll stay in your group as well.
Yeah.
And basically, yeah, if there's anything else you want, I think we covered everything in terms of, we didn't say your handle for, is it Hernia Doc? Is that what it is? Hernia
Yes. On Instagram and Twitter, it's at Hernia Doc.
Yep.
On Facebook, it's just Dr. Towfigh.
Awesome. Okay. So we have, I think we covered a lot. This has been really fantastic. And thank you all for joining us, and we'll keep this up. And yeah, and I think, like I said, we may have to do something like this again. We'll have to think.
I really enjoyed it. Thank you so much.
Yeah, you're welcome.
Okay.
All right. Bye.
Thanks, everyone.